This is the normally SFA disease pattern. We start with distal SFA, then we start with a short occlusion, and depending on the development of collaterals, it stays like this or it goes up to the origin of the SFA. Here you see three cases with very, very short calcified SFA occlusion distally, and a very long one, about 25 centimeters, not very calcified, but with a big collateral distally to the occlusion, and appropriate filling of the popliteal artery. In this study, the physicians tried to estimate on their own experience, is it better for long SFA lesions to go subintimal or to go into luminal? They had a kind of randomization, and they treated very long SFA lesions and found subintimal occlusion, the subintimal passage of the occlusion being more feasible, easier to cross with a better patency. This is something they found in another systematic review of several cohort studies comparing those or addressing those problems. The technical success for subintimal angioplasty was also about 80 to 90%, but they didn't use any re-entry devices, and they were subintimal fundamentalists, meaning they also passed lesions subintimally, even if it was just a stenosis or something. So went before the stenosis subintimal and came back distally and re-entered. Even though the one-year patency was very low, but they didn't use any stents. So for this systematic review, you can say this subintimal angioplasty is not the way to go. But if you have a long lesion, the subintimal way, distal calcification is the only way to go. It's the fastest way to go, but you face often the problem to re-enter distally to the patent artery. And then you can try with different guide wires, with angled catheters, with balloons, with poke a little bit. But in the end, you end sometimes way more distant to the initial occlusion. You balloon there, you close the collateral, and then you have to stent a lesion that was half of the length. Initially, you have to treat the whole lesion with a stent. This is something that should not be, and is not intended for treating subintimal long occlusions. Of course, the industry developed some devices to cover those problems. There are three devices available at the market at the moment. The outback catheter from Cordis was one of the first. The problem with the outback catheter is if you have to go very early for the outback catheter. If you try half an hour with different guiding wires and angled catheters, you open so much the subintimal space that you don't have support for passing the needle through the subintimal dissection. And of course, it's a very bulky device. You may lose the wire when you are bringing back the catheter over the aortic bifurcation. The Pioneer device is also a very nice device, where you have on the tip of the catheter, don't have any laser pointer now. On the tip of the catheter, you have an IRIS ultrasound head and the needle. And with the IRIS ultrasound head, you can direct the needle into the right direction. The problem is, you need an IRIS and a very expensive catheter. A much more easier way and more feasible is the off-road re-entry device from Boston. They consist of two devices, actually the positioning balloon, where you position the channel of the microlancet in the right place, and then with the microlancet you just poke through the dissection. Very simple, very easy, and hopefully not so expensive. Here are some examples of a very long SFA occlusion. Here, the failure to enter distal, the wire always goes subintimal far distal, and there's of course the danger to cut off this collateral. Here, with the positioning balloon of the Orbit device in place, you can really poke with a needle. You can see here the needle coming out of the balloon, poke through the dissection, and advance the wire into the lumen. Actually, it's a very nice system. Works quite well after stent implantation, nice result. Here's another example of a case. For typical SFA, long SFA occlusion with distal severe calcification, he suffered from a severe claudication, and there was really hard trying to get the guide wire through the distal occlusion. Here are some pictures. Hope you can appreciate the calcium of the distal part of the SFA. Patent 3 was the runoff. Subintimal approach, if you see a loop in the wire, you can always be sure you're subintimal. And then Here is the intent to poke the needle through. Actually, I cut this film a little bit, not showing you everything. Yeah, it works. Very good. The problem sometimes is with the Otto device, your needle is right straight, and sometimes you will stay in the subintimal. There's no danger that you poke out of the artery, but sometimes you have to reposition the balloon, take a little back, take a little forward, sometimes shake the needle a little bit to find the right rate. It's a little playing with tools, but in the end, a very good device to succeed in entering subintially or entering distally. And of course, if you're having a very calcified dissection membrane, it might be difficult to advance a balloon, so you need a low-profile balloon. It's an 14-inch guide wire, so you need something like a coronary balloon or a balloon that tracks over an 18-inch wire. Here, after stent implantation of 2 Innova stents, very nice result. Balloon post-dilatation with a very good clinical and angiographical result. So, for the subintimal approach, I can just summarize that the entering distal to the occlusion is sometimes very difficult. It is a problem that you dissect too further down, that you close collaterals, and if you don't stand the proximal or distal entry point, patency is really, really good. So should we avoid it? Of course not, because for long as an occlusion, it's the only fastest way to get things done. You cannot have a patient lying sleep out on the table to poke intraluminal to the occlusion. It takes too much time, and the patient will not stand this. So when do we go intraluminal? We do it, of course, when we have collateral as proximal and distal occlusion that we want to preserve. We do it when we want to do additional treatment. We want to use jugular balloon sometimes, that we think that the drug is going to the endothelium. Sometimes we do it when we use atherectomy. There was a question about atherectomy this morning. Atherectomy itself will not work, but atherectomy in addition to jugular balloon works quite good. Intraluminal crossing, of course, we don't extend the lesion too much to distally, so we don't have to have a full metal jacket for 10 cm SFA occlusion or something. And of course, we have no problems with re-entering, and we don't need additional tools to re-enter distally. Yeah, what kind of tools or guide wires do we have to achieve a passage of a calcified short occlusion? If you see this very, very short popliteal stenosis occlusion or something, it's not sure. This can be a really tough situation if you don't have the right tools in place. This was a case done very, very early, where we hadn't the right devices or guide wires in place. So as you can see on the third film there, this is the back end of a Terumo. This is a very, very stiff weapon. So you normally should not do it, but we call it the hammer and chisel technique if you just try to poke through the calcium. In this case, it did not work. Another option was then with the turbo elite laser to open up the fibrotic cap with a laser to make it more weak, that you can then pass through the occlusion. This sometimes works. In this case, it did, but we needed the back end of the Terumo just to get it through the calcium. And then in the end, we were possible to pass the lesion and to treat it properly. If you have such an occlusion as seen on the film, you really have a lot of wires in place just to make sure that you pass it. Our approach for non-calcified SFA lesions, of course, is the 18 control guide wire from Boston. It's a very, very hydrophilic-coated, shapeable tip guide wire. It's actually in our workhorse, in our CAS lab, we do with this wire anything because you can use it in so different places. Of course, there are dedicated CTO guide wires from a calcified lesion, brought to our country by the Japanese guys. It's a Astato or the Treasure guide wire from Asahi Intec. It has a 12 gram or 30 gram tip load. These are really weapons, but they're only 14-inch guide wires. The Japanese guys crossing everything, even if it's an iliac occlusion or SFA occlusion with a 14-inch guide wire. In our opinion, it's not appropriate because 14-inch guide wires are too small. Abbott has another wire in place. It's a Connect 250T. Actually, it's a kind of copy from the V18. Works quite well. Works again quite well. And Boston Scientific also brought up some new guide wire class Victory guide wire. They have it in 14-inch and or 18-inch design with several with 12, 18, 25, 30 gram tip load. They have it in short and of course in a 300 centimeter length. And it's a polymer coated guide wire, hydrophilic, with a very, very peak resistance shaped tip. So, if you don't have the guide wires, if you have tried every guide wire and you are not able to pass the lesion, what can you do else? There are several tools for going intraluminal to some kind of occlusion. In the beginning, there was the idea of having a laser. I showed you the laser is appropriate to really guide a wire through an occlusion. It's good for weakening the fibrotic proximal cap. Another device is a front runner catheter. The idea of this catheter is that you poke into the occlusion, and by opening up the proximal head, it opens up the channel for the wire, and you can really have small microdissection and entering through the occlusion. The problem with this system is that it has a really bulky tip. So it's really hard to enter with a 3 or 4 French head into an occlusion. Another tools is the Avenger Wildcat OCT guided catheter. The OCT is a kind of optical transluminal visibility of the occlusion, and the catheter is steerable, so you can steer in different direction and pass the wire through. Problem is we don't know really yet how this looks like in a really calcified occlusion. Another system from BART is the crosser catheter. The crosser catheter tracks over an 14-inch or 18-inch wire, and it continues or creates a high vibration at the tip of the support catheter. But for using this device, you need this machine next to the pictures directly at the catheter payload. So additionally material, additionally cost, not very good. Boston as well had here a good idea, and they brought up the TruePass CTO device, which actually is an 18-inch guide wire with a diamond-coated tip rotating at 30,000 rounds per minute. And it's shapeable. It's a nitinol wire with a hydrophilic coating. It's compatible to any 18-inch support catheter available on the market, the Rubicon, the Trailbreaker, the Seeker, the Quickcross, or anything you have in your catheter. And the wire is shapeable. You have a shaping tool. And with shaping tool, you can give the band 15 degrees of bend. And with this and the torque at the end, you can really poke your way through the occlusion. Then you have the handle. The handle tells you, okay, we have the motor started, we are entering in an occlusion, and of course there's always a red light. Red lines mean nothing is okay. Then you really have a high tip load, then you might pass to a calcium or pass to the vessel wall. Then you have to redirect it and have really an acoustic and also a visible feedback of how the device crosses the lesion. This even works so well that it's used even in below the knee arteries. Here you can see that sometimes it's really hard if you have a diabetic patient or patient on dialysis. The occlusion below the knee artery are very calcified, and it's really hard to get it intraluminal through. Sometimes it's even hard to pass it subintimal because of the calcium. And with this device, it's possible to pass it with a support catheter and with a rotating wire to pass this occlusion very well. There was a reopened study trying to get feasibility and safety of this device, and they enrolled 85 patients in vessels bigger than 2 millimeters and up to 30 centimeter lengths of CTOs. There was 55% de novo CTOs, and the other ones were the reocclusions. They were really moderate to zero calcified vessels, and the main lesion was of course the SFA, but also below the knee arteries. And they found they were usable, and they had a freedom from clinical perforation in almost every patient. There was some perforation due to other devices. And it was possible in almost 3/4 of all cases where in a previous guide wire attempt failed to cross the lesion. So the TruePass seems to be effective for crossing CTOs even when a normal guide wire or dedicated crossing wire does not work. So what do we do in the other cases? We are not passing from anti-gate, we don't, the re-entry device failed, the intraluminal passage failed. Then of course in a barrel situation we go in for retrogate approaches for CTOs. This is something we do always in a supine position. Of course there are some experience with popliteal approaches, taking and placing the patient in a prone position and doing the whole intervention from popliteal artery. What we are doing, we're leaving the patient in the supine position, so we can, of course, advance from proximal and from distally. From distally only the guide wire to pass through the occlusion. Here is the picture of the needle and line into the vessel, and then we are advancing in our 18-inch guide wire. In our case, this is the 18 control. Sometimes we do it with a sheaths approach, just a cord catheter over a wire, over the wire balloon. And sometimes you need a dedicated angle catheter, so we use a 4-French sheath from Terumo to place it from distally in the sheath. Then of course the question, how do we stop the bleeding? We just do it by compressing from outside. Before, of course, you have to pass the occlusion, you have to snare the guide wire. We do it normally in a diagnostic catheter, and after ballooning and stenting, nice result. So for long SPA occlusions, sublingual passage is the way to go. For shorter, calcified CTOs, interluminal passage with dedicated devices, guide wires, or crossing tools. And for interluminal CTO devices, the TruePass seems to be working quite well. The retrogate approach, of course, in barrel situation. Thank you very much.